Good day, viewers. My name is Tyson DeVoe, accompanied by Destiny Josie, and this is our presentation. Systemic lupus erythematosus, drug, belimumab. Systemic lupus erythematosus, SLE, is a chronic autoimmune disease in which the body's immune system mistakenly targets its own healthy tissues, leading to misspread inflammation and potential damage to various organs. Unlike other conditions where immune systems defend the body against harmful invaders like bacteria or viruses, in SLE, the immune system becomes hyperactive and produces auto antibodies that attack normal cells and tissues. This can result in an inflammation and damage to vital organs such as the skin, kidneys, heart, lungs, and joints. The exact cause of SLE remains unknown, but genetic, environmental, and hormonal factors are believed to play a role in its development. The etiology of systemic lupus erythematosus is multifactorial, involving a complex interplay of genetic, environmental, and hormonal factors. Genetic predisposition plays a key role with specific immune systems related genes and family history increasing susceptibility to the disease. Environmental triggers such as ultraviolet light exposure, infections, especially Epstein-Barr virus, and certain drugs can provoke or exacerbate the condition. Hormonal influences, particularly in women of childbearing age, also contribute as estrogen is believed to enhance immune activity. Additionally, immune system dysregulation, including the loss of immune tolerance and the production of autoantibodies, drives the immune inflammation and tissue damage characteristic of SLE. Together, these factors disrupt normal immune function, leading to the development of lupus in genetically predisposed individuals. Common symptoms include fatigue, fever, and joint pain, often accompanied by swelling and stiffness, particularly in the wrists, knees, and fingers. Skin involvement is frequent with the characteristic butterfly-shaped malar rash across the cheeks and nose, as well as discoid rashes and photosensitivity. SLE can also cause kidney problems such as lupus nephritis, which may result in edema, high blood pressure, and changes in urine. For example, protein or blood in the urine. Other systemic symptoms include chest pain due to pleuritis or pericarditis, neurological issues like headaches, seizures, or cognitive dysfunction, and hematologic abnormalities such as anemia, leukopenia, and thrombocytopenia. The pathophysiology of Systemic lupus erythematosus is characterized by a breakdown in immune tolerance, leading to the production of auto antibodies that target the body's own tissues. This process is triggered by a combination of genetic susceptibility, environmental factors such as UV light or infections, or hormonal influences. In SLE, immune dysregulation occurs with T cells and B cells becoming hyperactive, resulting in the overproduction of autoantibodies such as anti-nuclear bodies and anti-dsDNA. This antibody forms the immune complexes that deposit in tissues, activating the complement system and promoting local inflammation. This leads to widespread tissue damage and organ dysfunction, particularly in the kidneys, skin, joint, and cardiovascular system. The epidemiology of systemic lupus erythematosus includes that it is an autoimmune disease that is predominantly affects young women with a female to male ratio of approximately 9 to 1. The disease most commonly develops between the ages of 15 and 45, though it can be at any age. Ethnic differences play a significant role in the prevalence and severity of SLE, with higher rates seen in African American, Hispanic, Asian, and Native American populations compared to Caucasians. SLE is also more severe in the groups, particularly with kidney involvement. Geographically, it is more prevalent in North American, Northern Europe, and Latin America, with lower rates reported in parts of Asia and Africa, though it is found worldwide. The disease can occur in children and older adults. Belimumab. There is no cure for lupus, but medical interventions and lifestyle changes can help control it. The FDA-approved drug relevant to treat SLE, belimumab, also known as Benlysta. In 2011, the U.S. Food and Drug Administration, FDA, did something it had not done in 50 years. It approved a drug specifically for the treatment of SLE. Before belimumab, the treatment option to relieve symptoms and control the progression of the disease in the last 50 plus years include non-steroidal anti-inflammatory drugs and immunosuppressants.
The role of belimumab in systematic lupus erythematosus is to prevent the binding of BLyS to a B cell receptor. BLyS, also known as BAFF, is naturally occurring in the body as it is responsible for the proliferation and differentiation of B cells. These B cells would then be stopped from differentiating unnecessarily, and they would not be present in plasma cells, activating the innate and adaptive immune response. There are two main types of cytokines that act in SLE, which are BAFF, also known as BLyS, and APRIL. These two are responsible for B cell proliferation and differentiation. Bilimumab does its main job by binding to the BAF with the help of BAF, R which inhibits autoreactive B cells from maturing. While this is happening, the receptor APRIL is not affected, with results in B cells not being affected, and the activity of B cells can continue. BAF is responsible for producing memory B cells. However, with it being inhibited, this cannot occur. Now we would move on to about the drug. So the dosage. The recommended dosage is 200 milligrams once weekly, given as a subcutaneous injection in the abdomen or thigh. Subcutaneous dosing is not based on weight. If transitioning from intravenous therapy with Benlysta to subcutaneous administration, administer the first subcutaneous dose 1 to 4 weeks after the last intravenous dose. The recommended intravenous dosage regimen is 10 milligrams per kilogram at 2-week intervals for the first 3 doses at 4 weeks interval thereafter. Reconstitute, dilute, and administer as intravenous infusion over a period of 1 hour. Efficiency. According to the physician, assessment at 6 months, 251 patients achieved about 20% improvement, and 134 patients achieve about 50% improvement in overall clinical responses to Bilimumab. No disease flares were reported at month 12, 18, and 24 in more than 99% of responders. Adverse effects, mortality, serious infections, hypersensitivity reactions, including anaphylaxis, infusion reactions, depression, and malignancy. Contradictions. Benlysta is contradicted in patients who have had anaphylaxis with Bilimumab. Now brings us to the pharmacokinetics of Bilimumab. Absorption. To reach maximum serum concentration in the body, it takes approximately 2.6 days. Distribution. The distribution half-life is 1.8 days. Excretion. It takes the body 19.4 days to rid itself of Bilimumab. Now brings us to our conclusion. To conclude, SLE is a severely debilitating and potentially fatal disease that can have significant impact on productivity and quality of life. There is currently no cure, but the drug Bilimumab, Benlysta, when combined with the standard of care, has the potential to delay the disease progression and improve clinical outcomes.